they don't really make any difference unless you can change some human behavior. At the end of the day, we need a patient to change their behavior, and potentially a provider to change their behavior.
Hello, everyone, and welcome to the Strategy of Health podcast. My name is Lyons from the American Journal of Healthcare Strategy, joined by just an incredible guest today from a company that I've been working with for a while, who is doing just really incredible things, not just for the kidney population, but also as a template and an example for the rest of the healthcare industry. Please introduce yourself, Joe.
Nice to talking to me, Cole. Joe Vattamattam. I'm the co-founder and president of Healthmap Solutions. Started the company in 2013 with some other co-founders, and I'm happy to say we're still here and doing great things for the chronically sick population, specifically those people who have chronic kidney disease or end-stage renal disease. We've been doing that in particular for the past 10 plus years, and we've helped tens of thousands of people across the country have improved health, avoid adverse events, and we'll be as bold to say that we've saved some lives. So really excited and proud about what we've accomplished here and what we continue to do at Healthmap Solutions. And before that, I worked at a company called CareCentrix that was focused on home-based care, post-acute care. I led the medical economics team. We built products while we were there, so I was part of a team that would do that, and a little bit of acquisitions of certain companies to be able to really drive care into the home. Mm-hmm. And prior to that, I worked at WellCare. We saw what things were like on the payer side of the fence, serving government programs, so Medicare and Medicaid. And prior to that, I was an investment banker. But pleased to be with you here and excited for the conversation.
I'm pleased to be with you as well. And just so the audience knows the context, we've had, of course, Eric Reimer. He's CEO right now as well. We've had him on twice. We've had Dr. Stephanie Toth-Manowski on once, Dr. Beth Malco on, Tom Gaffney. And so we've had most of your kind of team on, or your senior team. And I think they've really impressed the audience with a lot of things. One of the questions that I have for you, how did you get these skills to build such a good team and to get so many of these great people that you've kind of surrounded yourself with? How did you do that? How did you get that skill set?
Well, look, I think we're very fortunate to have the team that we have, right? So I don't know that I've ever worked with such a strong management team that has such a great background of success in other areas and has the amount of passion and energy and excitement around doing what we do here at Healthmap. I'd say there are a lot of, just even beyond those executives that you mentioned and the other people that are sort of in the C-suite, so to speak, I would say all of our leadership, and for that matter, almost every employee we have, I would venture to say a lot of folks here could be doing other things. They choose to be at Healthmap because we have such a strong culture of mission here, right? We're really focused on improving the lives of people who have chronic kidney disease or multiple chronic conditions, as people with kidney disease do. And I think that gives people a great sense of purpose, right? To be able to put their talents to use on what is really a noble cause. And I always like to say, that our mission is real because we align the money to the mission, meaning the only way we get any revenue is by reducing the cost of care. Mm-hmm. And the way we reduce the cost of care is by reducing the unnecessary admissions and visits to the emergency department. That's how we really drive value. And so while it might sound altruistic to say it's very mission driven, it's very realistic for us, right? Because that's how our economics are structured. I also think that I'll attribute a lot of that towards a lot of the leadership team and being able to attract folks, less about a skill set that I've acquired and more about just you get one great person from a place, and good people want to work with other good people that they've had success with in the past. And you look at our team, we have a lot of that, a lot of connections in the past. I mentioned I worked at CareCentrix. Eric was the CEO of CareCentrix. And when I started this company, I sought Eric's advice immediately before me and the other co-founders started the company. I talked to him. I said, hey, here's what I'm thinking of doing. What do you think? And so in an unofficial way, he'd been involved, at least with me from the very start. Mm-hmm. And when you look at Tom Gaffney, he and I worked at CareCentrix together. A lot of folks worked there. Some folks came from CareCore or Evercore. There's a little group there, and it's fun to be all working together again in this one common cause.
I've noticed that a lot, that there is this deep kind of pride and appreciation for the work. And that kind of goes to my next question. You have an MBA, you have a mathematical finance background. Kind of one of the questions is why, when I Google, Joe Vattamattam today, you are known for quite well in the healthcare space. And you say it's not altruistic, and it isn't. It's very realistic. I've, talked about the numbers a lot with Tom, the growth numbers. But at the same time, it is a very kind of altruistic mission, and it is a very positive mission. So why, when I Google you today, are you this kind of very health focused? You care a lot about the patients. Why didn't you go into investment banking, I guess? And what skills did you kind of learn from that time period with your math background, with your MBA background, with your investment banking background that maybe you didn't expect would benefit you so much at first?
Yeah, I mean, I think all the quantitative work that I've done in my past has served me well in the work that we do here at Healthmap and starting the company and really sort of setting a strategic vision. I think we're very different from our competitors, and I do think that a lot of that has to do with our approach when we first decided the kidney disease space is the space for us, right? We looked at it and really was focused on how do we reduce the cost of care by improving clinical outcomes. And when you look at that, it really sort of drives a product market fit. And I think that's what set us apart from others and has helped us to have a lot of success. And a lot of that had to do with analytics in the very beginning, just how do you even approach this? And I would even say some of the work from banking and figuring out how to create a business that can create value, have the right types of economics with the right types of aligned incentives, all mattered a lot. I'll give you some concrete examples.
Yeah.
Started down this path, and intuitively, when you think about the kidney population, you think ESRD members who are on dialysis or have a transplant are your highest cost members. Start there. That's where you should try to drive the most savings. At least on a per member per month basis, they're going to spend the most. And that's true on average. That is very true. But what we learned over time in speaking with physicians, because it's such a clinical program, we learned that if you expand the aperture and you go from CKD stage 3, chronic kidney disease stage 3, which is mid stage, all the way to end stage. At that point, ESRD patients represent 15 to 20% of your costs. Stage 3 members who are mid stage will represent about half of your costs. So half of your opportunity is going upstream before you even get to those really high cost members. And so for us, we said, oh, wow, that makes sense analytically. So let's go upstream. And it also makes sense clinically because it's your window of opportunity to be able to drive better care so that hopefully you never progress towards the late stage or even the end stage. The best way to reduce your dialysis costs is to never need dialysis. Right? And as a human being, you'd much rather never need it than to have it. So that's one example. Another one, intuitively, people will think, we should be working with nephrologists to manage these members. And that's true. That's absolutely true. And Healthmap works with nephrologists very closely. But what we did realize is when you look at the data, 60 to 70% of CKD members have not seen a nephrologist in the past 12 months. And that's true, not exactly those same percentages, but a big portion of members who are stage 4, stage 5 even, have not seen a nephrologist. So we realized if you're going to be effective in being preventive upstream, you have to go broader. You have to work with nephrologists, but you also have to include PCPs, primary care physicians. You have to include cardiologists and endocrinologists and other physicians. So we realized, and again, I'll credit analytics there, to actually be able to reach all of the members you want to reach, you have to include nephrologists and include some of the other specialties. And then the last one I'll give you, because it has a lot to do with AI and machine learning. We looked at the population. Everyone would say, look, if you have chronic kidney disease, you have multiple other comorbidities, you're going to be an expensive patient. That's true some of the time. What we found is 30% of the population tends to represent 80% of future costs. So when we saw that, and we saw that it was consistent, we realized we have to develop a predictive model here where we can identify that 30%, make sure that we're managing them as best we possibly can in collaboration with their physicians and with them, of course, to be able to stem and bring down future costs. So that was kind of like the start of it, right? Now, doing all that analysis was strategic analysis to say, is this the right space to go into? When we saw all these opportunities, all these gaps, we said, yeah, it is. And then that informed our strategy, how we have to build this program to be able to make sure that we're successful in managing the population.
In engineering school, they will talk about how bad humans are at predicting events, specifically like kidney disease, specifically actually like crash to dialysis or a lot of the, hospital acute issues that come up. Humans are really bad at that. And so many companies forego dealing with clinicians, right? They say, I don't want to deal with clinicians because I can figure this out from the data. But and some companies have found success with that, right? They produce, pure data models and that's all they do. But you've taken a very different approach. You didn't just produce kind of an AI model or a computing model or, a predictive analytics suite. You didn't do any really of that standalone, right? This was very different. And you, from the very beginning, were working with clinicians, right? This was not we're starting to gain steam, the model's working, let's bring on some clinicians. So you had a very different approach entirely than some competitors, right?
I would say every one of us has approached this, us and our competitors, from a clinical standpoint, right? So I would give them all that credit, certainly. I mean, when you're working with a population that's as sick as ours and as complex as ours, it cannot be all analytics. You have to have a very strong clinical background and presence and knowledge base. And candidly, that informs and works with all the analytics that you do. Everything we try to drive with our provider partners and with our members is based on evidence-based guidelines, right? It's just a matter of being able to take the hundreds, thousands of guidelines that are out there and distill them down to the thing that matters most for that patient and that provider at that moment in time. And that in itself has been an entire AI exercise for us. And we call it next best action. And it's what is the next best action for that member at that time. But the reality is, like, you could never, at least in my opinion, you could never really be effective trying to operate this program and just going direct to the members, because these members do see 3 to 4 different providers, physicians in a given year. Yep. And they're on 15 to 20 different medications in that given year, all prescribed by different people. If you want to affect their healthcare in a positive way, you're going to have to work with their physicians. And the physicians are just a central part of it. So yes, from early on, we said, look, this has got to be a clinical program, an analytically and economically sound program. And so therefore, we do need to work with the physicians really closely and be partners with them.
That's great. I very much agree with that approach. It's funny, going back to the engineering school, one of the things that a lot of people do not realize, as they're building these healthcare-centric projects, is what happens when you go to the implementation phase and you have not involved clinician leaders. Do you feel like it's a bit easier when you're discussing with health systems about potentially partnering, or health plans about potentially partnering when you have clinical staff already, and even yourself, right? Coming from an MBA background, you must have become much more used to clinical terminology and familiar with clinical terminology as time's gone on, right?
Oh yeah, absolutely. Early on, we didn't have the luxury of having a chief medical officer. And so, I had to learn as much as I possibly could. And of course, that falls far, far short of being a doctor, but it at least allows me to converse in a way where I understand some of the challenges that and can articulate some of the challenges the population's facing. But really, the second that you want to start working with health plans, it's a clinical value proposition.
Yep.
That the company provides. So therefore, we're talking to the chief medical officer or their team, or chief population health officer, which also tends to have some clinical folks on that team, when we're suggesting that they work with us. And so we have to have that same clinical team. And you mentioned Dr. Top, who you spoke with, so practicing nephrologist, and we have Dr. Howard Shaps, who's our chief medical officer.
I forgot to mention Dr. Shaps. I can't believe I knew I was missing someone.
Yeah. So we have a great clinical team that really understands nephrology, kidney care, and also managed care, what it's like to be on the payer side of this, trying to manage a population. So yeah, absolutely. We have to have that capability. And like I said, it's part of the program, part of the product, always has been. And so we want to make sure that we have clinicians with us to help bring that to the forefront in any conversation.
That's great. And thank you for, I really wanted to hammer that home, because my next question is about the AI part of things, right? And so I wanted to make sure the audience was aware that, clinicians are such an integral part of the process, but there's also this kind of, I like to call it the secret sauce of kind of Healthmap Solutions. What I tell people is this predictive kind of analytic system that is looking 6 to 12 months in the future, which is crazy because a lot of predictive analytics programs only look at when the patient enters the hospital, right? And those are of course, complex. But you must be dealing with thousands of variables, and, just reading in an AI class about, random forests and whatnot, as you increase kind of the number of potential variables, you kind of increase the correlation between them. And it's very complicated, but you seem to have found a real solution to this. And then there's also this kind of acquisition of Carium and a lot of things happening. How are you able to get a model that's so successful in predicting something that is so far into the future, 6 to 12 months? I mean, that's impressive.
Well, I appreciate that. All of that. It is a challenge. I'll say, first, I think we recognized going upstream and identifying those members who have a lot of volatility in their healthcare utilization was important, because if they have volatility, it means, well, some might utilize a lot, others utilize less. And so if you bring the high utilizers down, and that's possible as evidenced by the lower utilizers, that's the goal. That's what you're trying to do. And so for us, going upstream is incredibly important. Being able to take in all of that data and create a predictive model. I'd say, there's a couple of components here. One is just our experience. We've been doing this for over 10 years. We've at this point analyzed over $30 billion of healthcare expenditures related to people with kidney disease. Potentially one of the richest data sets of kidney disease in the country. So that's enormous, because it allows us to be able to take all of that data, pull it together, and analyze it to a point where you can identify and classify members into different sub-segments, cohorts, and off of that, be able to identify certain patterns that happen and related attributes that would indicate that pattern is likely to happen, that pattern being high cost, admission, ED visit, et cetera. So just the vastness of the data that we have is part of it. I would say, once you come up with a predictive model like that, it can come across as like a black box type of structure. So our AIML team has done a great job of creating what we call a driver report. So it's sort of an indication of what might have made a person very high risk, right? So we run all of the data through our predictive model. That predictive model then indicates if somebody is high risk, medium risk, low risk, which really like kind of oversimplifies it because everyone gets an individual score. And then at the end of that, we also have a driver report that would say, hey, for instance, this person has a neurological and musculoskeletal issue, and they've been on anticonvulsants, and this is why they're really risky. And oh, by the way, they had recent healthcare utilization. They had they're starting to run out of a certain supply of medications, and so this is something to look out for. And this is why this person could be high risk. When you couple that predictive model with the driver report, then you want to be able to put that into the hands of a clinician on what we call our front line, right? Affectionately, meaning they're on the front lines of working directly with physicians and directly with the patients. So they have this information and they're able to converse at a very meaningful way and say, hey, we noticed you're running low on these drugs. We noticed you've had these neurological, musculoskeletal issues. We also know you have chronic kidney disease. Let us help you navigate the next 30 days, 60 days, et cetera. And by doing that, they're dramatically reducing the risk of that person having an admission going forward. So we're changing that outcome by virtue of giving them that right risk level and the right information. And I do want to credit, I've mentioned our AI ML team. Separately, we have an entire technology team who is tirelessly labored over our tech platform to be able to take in all of those insights and make it seamless for those frontline, clinicians and non-clinicians working with providers and members, so that it's all within their workflow. It's very clear what needs to get done next for which patient, and then they can move on into the next patient. It just allows them to operate at the top of their license. And I think the connectivity between the AI ML stuff and the technology platform is where the magic really happens for Healthmap, to be able to, at scale, and be nimble enough to be able to effectuate the right change and make the right impacts that we're seeking to make.
How were they able to do that? And I ask this because the better a model is generally, the more of a black box it is, right? Like the harder it is to identify, the millions of weights that kind of contributed to that. And so when you're looking at a patient, how were you able to kind of have the data go into the machine and have it give them a risk score? And is that a 1 to 100? Is that how that works? Or is that a proprietary scoring model that you guys have in terms of that?
It's a proprietary score. Okay. And then the driver report is like a model on its own. Right?
Oh, so that's how you have a separate model for that.
Yeah. So it's like a model on its own that needs to then pull out the right information. So,
wow.
So I would say they obviously relate, right? Yep. So you have the risk score that gets generated, and then a related model will say, well, here are the drivers of it. I'd also say, you mentioned Carium, Cole, which has been just a phenomenal acquisition for Healthmap. I think a few of the things that really stand out for us with the capabilities we acquired here. When you think about the role of our organization, all of those analytics are great, but they don't really make any difference unless you can change some human behavior. At the end of the day, we need a patient to change their behavior, potentially a provider to change their behavior. It's one thing for us to use the power of science and analytics to identify an opportunity for a patient, but ultimately we need that patient for it to come to life for them and for them to drive it. And that's what Carium does for us. It operates, our CIO always likes to say, and I like this, it operates at the healthcare delivery edge. It's really focused on enhancing our abilities to deliver our programs to patients and providers, right? And to be able to do that in a very intuitive way. And ultimately, it connects not only patient, provider, but also Healthmap clinician to be able to ensure, like, hey, any leading indicator signals that we get could be from a wearable, it could be from something else, gets factored into all of those analytics and then presented to all those stakeholders at the right time for the right action.
So the Healthmap model it's going back and forth between Carium, essentially. It's feeding that data in and it's pulling data back.
Carium's like a phenomenal conduit that then also helps us to visualize all of this complex information in an easy to act upon way.
Wow. Quick question. This is a bit of a side question. You mentioned wearables. How recent was that you integrated that, into the model? Have you seen any interesting results? And I ask this because a lot of people talk about it as a feature, and then when it comes to integrating it, it doesn't usually, go very well. So I'm intrigued to hear about that.
Yeah, so Curium's had that capability. It's one of the things that they've been doing for years now. So as we brought them on, and Healthmap has the capability, pre-Curium, but probably just multifold boosted our abilities by bringing them on. And so that's been really kind of a bit of a game changer in adoption. We're just getting it started, just getting it going. So we're a little too early to talk about any results to it. But we're really excited about the promise of it. And I know that, Curium's had plenty of past success leveraging remote patient monitoring. We mentioned wearables, but I also think of RPM in the same bucket. Things like, data from weight scales or cuffs or, et cetera, like glucometers. So for us, it's really more that type of biometric data that's really interesting. In addition to what you get from wearables. And I know that there's some out there that says, look, maybe the heart rate off of an app, a smartwatch might not be as accurate. And that may be the case. It's hard for me to opine on that necessarily. I myself haven't done a ton of research on that, but I do know that there's a lot of value in the remote patient monitoring data set.
That's exciting. So a future podcast episode, then we're gonna have to get you on. And that's kind of actually the last question is about the future state. I talked to Tom about this, and he said, "Oh, we're really focused on the kidney, the CKD right now." But I just see this as such an opportunity for CHF, for COPD, for so many more things. And I'm not just talking about the technology. I'm talking about the team as well. I mean, it's rare you find a team like this, and a company culture as well is so geared to it. What do you see the future as being? What is next? What in 2030, where are you guys going to be at? And of course, not asking you to share anything secretive, but anything you can give us is definitely intriguing.
Well, I'll tell you, I'm so excited about what we're on the cusp of, right? We're leveraging this AI boom. We're leveraging some of the technology platform build that I mentioned our team has been working so hard on, and the combination of that with Curium and our clinical know-how, right? And by combining all those things, we're sort of right there at the point to be able to completely change the way population health gets done for the kidney population, and drive even greater improvements from where we are today. I do think that can be replicated across other very chronic conditions or multi-chronic conditions. I do think it sort of is a game changer overall, and it could be industry-wide as well. So on the horizon for us is, yes, other disease states that look similar in terms of the sort of clinical value prop that kidney has. When you think about what we do here, we manage much more than just the kidneys, right? A person has kidney disease. That's sort of I always say that's their ticket of entry into the program. But once you're in, we're working on everything with that member, right? We're working on their cardiac issues, COPD, behavioral health, social determinants of health. So it's a pretty comprehensive program. To focus on a different disease stage has a lot more to do with the profile of that population. What are the big spike clinical events? What I mean by that is, like in kidney disease, it would be, we have to go on dialysis. In cardiac, it would be, I have heart failure with reduced ejection fraction, right? HFrEF. We have models for that as well, predictive models for that, because it impacts our population. I think for each one of these disease states, you could find that big event and try to manage ahead of it to try to prevent it from happening, or manage the patient's care really well through those events if they unfortunately do have to happen. But even beyond that, I think the technology platform and the process and the way we're working with our own clinicians and then others is a model that can get replicated. And I would love to see that used all over the country with as many payers as possible.
Well, so stay tuned then is
Stay tuned.
the guy. So that's wonderful. So everyone, thank you so much for tuning in. Joe Vattamattam, the co-founder and president of Healthmap Solutions. Thank you so much for joining me, Joe. It's great to meet you for the first time, face to face here. I hope you'll join us again, and I hope the audience enjoy. They have your LinkedIn. Healthmapsolutions.com, of course, is the link for any of those who are interested in learning more. And I hope that we get to work with your team again in the future.
Thanks so much, Cole. I really appreciate the opportunity. It was great to speak with you.